So our second speaker of the day is Dr. Kayla Wolofsky, currently a clinician teacher at Toronto General Hospital at the University of Toronto. And her clinical duties include both general internal medicine and palliative care. Her academic work and focus is on general medicine, palliative care, global health, and medically underserved populations. Dr. Wolofsky, the screen is yours.
Thank you so much, and I'm so honored to be here to speak to you today about symptom management in humanitarian settings. I want to name a dilemma. I am coming to you and talking to you from Canada, where we are very privileged to have many medications. I did my best to collaborate with various colleagues, many of those who are on this call, to ensure that the medications I speak about you have access to. I recognize that you might not have access to some of the medications that we do speak about, but I do think it's important to advocate and try to find ways to make these medications more available. And I want you to be aware of what is available so that we can get these medications to you. I'm happy to discuss afterwards if there's any other questions or comments that you might have about alternative therapies. I think this needs to be an open and frank discussion. So thank you so much for inviting me. My objectives today are to ensure that you can understand common symptoms in advanced disease and in things like chronic disease in adults. I want you to learn how to assess and manage things like pain, dyspnea, so shortness of breath, nausea and vomiting, anxiety, and agitation. Now, this is a lot to get through in 25 minutes. So if I speak too fast, please let me know, and I will do my very best. I'd like to present a case study. Here we have Ahmed. He's a 57-year-old man with pancreatic cancer, unfortunately with mets the lung and liver, and likely other places such as the bone. He currently lives in northern Uganda. He has a wife and 2 sons who are quite young. He's a former day laborer, but unfortunately has not been able to work for several months due to worsening symptoms, and these include pain, shortness of breath, and nausea. Your role is to visit at home and to assess his symptoms. When you ask him about his symptoms, he has many. He reports pain in his abdomen. He's got very shortness of breath with any exertion. Of course, his anxiety is related to some of the symptoms he's having, and he worries quite a bit about his future. Unfortunately, whenever he eats, he becomes quite nauseous. His pain is quite generalized in his abdomen, and he rates it about 8 out of 10 on most days, so quite severe. His shortness of breath, as mentioned, gets worse with activity. He's tried things like bronchodilators, he's had increased airflow, so he's opened windows, he's gotten a fan. At times, he's been able to access oxygen. As mentioned, all of these symptoms and the worry about his family has caused him quite a bit of anxiety, and especially at night when things are quiet. His other symptom is nausea. Unfortunately, with any smell that he smells, he becomes quite nauseated, and anytime he tries to eat, he throws up. How do we manage Ahmed? So the first symptom I'd like to talk about is pain. One of the most important things when thinking about how to manage pain is taking an excellent history and then learning how to prescribe and titrate opioids. But really also what I want you to learn is how do we select alternative agents to opioids and how can we use them in parallel? So just thinking about pain as a global picture. Now, I'm sure many of you have heard about different kind of acronyms about how to take a pain history. One of the ones that I like to think about and find to be the most generic is thinking of OPQRST. When taking a pain history, it's really important to better understand the onset. What causes it to happen? How long has this been going on for? What does it feel like? For P for palliative, think about things like what makes it better? Lying down, not moving? Have they tried anything over the counter? Have they tried any type of remedies, whether it be herbal or heat or massage, and did it help? Any breakthrough medication that they've tried? The next thing I think about is quality. What is it like? Describe it. Is it sharp? Is it stabbing? Is it throbbing? Understanding the quality really does help us choose what agent to potentially use to treat our pain. Radiation. Does it spread anywhere? So sometimes pain is very tricky, where you might have pain in your shoulder, but actually the problem is in your diaphragm. You might have pain in around your belly button, but really the source of the pain is in your lower abdomen on the right. Pain has a way of radiating to places that we wouldn't expect. The other thing I'd like you to think about is severity. And I know it's quite challenging, and there's different ways to think about how to rate severity. The one here that we're going to talk about today is the number scale, so 1 to 10, and better understanding how does it affect your quality of life. Part of the reason it's helpful to have that number scale is it gives you a quantitative way to think about pain. And then you can compare to when you try a treatment to see if it improves. So if today I tell you my pain is 10 out of 10, we try Tylenol or paracetamol and it gets better, and it's an 8 out of 10, that gives me a number to compare to. And lastly, temporal factors. Does it come and go? Is it worse with activity and meals? A pain history is one of the most important things you can do in addition to an exam, and the reason being is it really does help you choose what agent to use and to better understand the cause of pain. Now, obviously, people do years of fellowship to understand pain, but I do think there's some important concepts to understand. Pain can be broken down in 2 different types, nociceptive and neuropathic. Neuropathic is your very sharp shooting pain, and that's pain that is caused by nerves. The nociceptive is something that we feel like, for example, let's say you get hit in the arm or you have a surgery, and that can be whether it's in your abdomen or kind of peripherally. And the reason this is important is, again, is it does help us determine what kind of pain medications to use. I'm sure many of you have read or heard about the World Health Organization pain ladder. There's multiple variations of this, but I'd like to focus on the 3 different rungs that is historically the most used. Recently, there's been a 4th rung, but for the purpose of today's lecture, I'd like us to focus on these 3. When someone has mild pain, it's really important to try to use a non-opioid, which we'll talk about in a minute, and any kind of additional therapy. And that additional therapy, again, could be massage or heat or another medication. As the pain starts to intensify, and again, this is very subjective to your patient, and this is where the number scale can help. So for mild to moderate pain, which some could argue being a 3 out of 10 to a 6 out of 10, we might consider a weak opioid and another non-opioid plus a different type of therapy. And then as we get higher to the moderate to severe pain, which some would define as 7 out of 10 and above, that's when we start to think about using strong opioids, another non-opioid, and again, a different type of therapy. So as you can see, we try to slowly increase up this ladder as the pain increases. It's really important that we think about opioid-sparing agents. And the reason being is that opioids, again, I recognize are not easily come by. And also they have significant side effects such as constipation. So what agents can we use in addition to or before we even start to think about opioids? One of the best and most basic medications is paracetamol. This is a wonderful pain medication. It doesn't cause drowsiness, it doesn't cause constipation, and is very well tolerated. This usually comes in tablet form, and we need to think about dosing. If someone does not have liver disease, I recommend not going above 3 grams per day. So for example, if someone is able to obtain paracetamol, ideally they would take 2 tablets of 500, so 1,000 milligrams 3 times a day. If you suspect your patient has cirrhosis, I wouldn't go above 2 grams. But again, paracetamol is a wonderful agent for any kind of aches and pains and can be quite generalized. Additional agents, which I find very helpful, and this is where understanding the pain is good, is neuropathic agents. There are two different medications that we commonly use, pregabalin and gabapentin. These are pains that someone might describe as sharp and shooting, or burning sensation, or tingling in the hands if someone's got diabetes. Of course, use whichever medication you have access to, and I've got your doses here. So pregabalin, you can start around 50 to 75 milligrams once a day, and you're going to titrate up to a maximum dose of 300 milligrams twice a day. You have to be a bit careful in patients with renal disease. Gabapentin is a much higher dose. It usually comes in pills of about 100 milligrams, and you can get up to 3.6 grams per day. This medication is taken 3 times a day. In terms of which is better, it really depends on what you have access to. Gabapentin can have quite a number of pills because of the higher doses. Pregabalin usually comes in 1 or 2 pills. The other thing about gabapentin is you need to be cautious in patients with liver failure. But again, neuropathic agents are great for that sharp shooting pain, the tingling in your hands or feet, someone with diabetes, or someone who might be getting cancer treatment and there's side effects. Paracetamol is a general agent and is very well tolerated. The next medication I'd like to talk about is anti-inflammatories. Anti-inflammatories are very good for abdominal pain, so visceral pain, especially if someone has cancer or has bony mets, or let's say they have really bad bone pain. I recognize you can get corticosteroids over the counter in many places. I just want to caution their use. They're excellent because they inhibit inflammation and they reduce edema, but I just want you to be aware that there are quite a number of side effects, like things like increased glucose, so hyperglycemia. With long-term use, you'll have muscle weakness. And you do have to be careful if someone's on steroids for quite some time because it can suppress their adrenal glands, so their own body's ability to mount a steroid response. If you choose to use dexamethasone, the doses vary, but you can essentially use 2 to 4 milligrams once daily. And I would recommend using it in the morning because someone who takes dexamethasone will be much more awake, much more alert, and might have difficulty sleeping. Your other option are things like NSAIDs, so non-steroidal anti-inflammatories. These, again, you can get over the counter, and very commonly you have ibuprofen, and I usually prescribe around 400 milligrams 3 times a day. The other medication that I understand is available is diclofenac. I didn't put dosing in because there's actually quite a number of various formulations, and so the best thing to do is talk to your pharmacist. NSAIDs are wonderful to work with alongside paracetamol, and you can schedule them at the same time because they're different types of medications. So someone, for example, if they have extreme pain, you can give 500 milligrams of paracetamol and also give ibuprofen 400 milligrams at the same time. That is safe. With NSAIDs, I do need to caution you that if someone is bleeding, that this can worsen bleeding. If someone has renal failure or heart failure, these are not ideal medications to use, and they can also cause upset stomach. But of course, if someone is in a crisis, then ensuring pain relief is the most humane thing you can do. The next level, like we spoke about, is opioids. And this is that top rung. So someone who is in severe pain. So 7 out of 10, the other medications you've tried are not working. I understand that oxycodone and hydromorphone are not readily available, but I do want you to know that they exist. And my hope is one day that you'll have access to them. Medications that you might commonly have heard about are things like codeine, which you can start at 15 to 60 milligrams every 4 hours as needed. The other 2 medications are things like tramadol and morphine. So tramadol is considered a more weak opioid. So if you remember that second rung on the ladder, this is an example where you would use tramadol. Start at 50 milligrams every 4 to 6 hours as needed, with a maximum dose of 400. And lastly, morphine. I know it very much depends on where you are, whether you have access to oral, IV, subcutaneous, or you might only have access to IV. And so I'd like to give you a recommendation of a starting dose. So morphine orally Ideally, you start at 2.5. So if it only comes in 10 milligram tablets, you would cut it into quarters to 5 milligrams every 4 hours, orally PRN. This is a good first line drug. What I wanted to show you on the table to the right is just how you convert between oral and IV. In general, the way to think about it is you divide it by half. So if you're starting morphine 5 milligrams and in an oral and you want to convert it to IV, divide by 2. I just wanted to teach some basic opioid pharmacology. The big picture is it takes about 30 minutes for oral morphine or codeine or tramadol to work. It peaks in about 60 minutes. So if your patient hasn't had relief in 60 minutes, this means you need to give another dose. And oral opioids only last for 4 hours. Okay, so it will start to wear off. For IV, the reason some people prefer this, especially in crises, is it works much quicker in 15 minutes. But as you can see, the duration of action is about 4 hours. So how do we prescribe opioids? If someone is in severe pain, you can give opioids every 4 hours because this matches how long it should work. If you know someone has any kidney or liver dysfunction, I would space it out to 6 or 8 hours because that's how it's cleared. If you're scheduling it every 4 hours, it's reasonable to give your patient a breakthrough dose every 1 hour to match that kind of peak effect. And so usually we'll do about half that every 4-hour dose. Again, caution in patients with liver and kidney disease. Next, I'd like to talk about shortness of breath, so dyspnea. There are many causes of dyspnea in someone that you in palliative care. And this can be due to cancer, infection, just airway disease such as COPD or asthma. They might have fluid in their abdomen pushing up against their diaphragm, which is causing them to feel short of breath. Maybe they're bleeding, and this can cause, and of course, anxiety. Now, I'd just like to circle back on what is the definition of dyspnea? This is someone who feels like they can't breathe. So, for example, their oxygen saturation might be normal, but they just have this sensation that they can't breathe, that they're gasping for air. So it's a subjective feeling. The best way to manage this is two various ways. Well, 3, sorry. You want to educate your patient. Just because someone has a change in the respiration rate doesn't mean they're uncomfortable. Like I mentioned, oxygen saturation doesn't necessarily correlate with their subjective feeling. And what we're trying to do is change the perception. Things that you can do that don't include medications are just putting cold cloths on someone's face, having them sit upright, and sometimes even leaning forward, having a calm and quiet atmosphere, because as you can imagine, they're going to be quite anxious, and if possible, oxygen. And that can mean many different things. That can mean a fan, a hand fan, a rotating fan. If you have access to oxygen, you can put oxygen on, and this can be quite calming. If you're going to use pharmacological management, morphine actually does help. It's a little bit unclear as to how it works, but what we think is it calms the diaphragm. So you can use morphine orally or IV or subcutaneous. And again, your starting dose orally is going to be 2.5 to 5 milligrams every 4 hours as needed. Codeine also works. And again, going back to steroids, steroids can also be quite helpful. And again, you're going to start at a dose of 2 milligrams per day. If someone is end of life, not being able to breathe is the most terrifying thing. I would highly recommend, if you have access to it, giving some kind of anxiolytic, whether it be lorazepam or oral diazepam, which you can give orally or rectally. Let's meet back with Ahmed. Unfortunately, Ahmed has slowly developed fluid in his abdomen, and he's having significant nausea and vomiting. He can't really identify very clear triggers. He believes it might be associated with smell and food, but he also hasn't had a bowel movement, unfortunately, in several days. There's no blood in his vomit. There's no other concerning signs, but unfortunately, he has no appetite and is slowly losing weight. The next topic we're going to talk about today is nausea and vomiting. I recognize that this slide might be a bit complex. There's a few key takeaway points. Nausea and vomiting has multiple mechanisms. It depends on which receptor is being triggered. And the reason this is important is because it really does help us decide which medication might be the most beneficial. There's receptors in our stomach, our small intestine, and vagus. And as you can see, these are triggered by things like chemotherapy, surgery, radiotherapy. There's something a little bit higher in the chemoreceptor trigger zone. Then there's our inner ears or vestibular apparatus and our cerebellum in our brain, which helps us with movement. And then there's the vomiting center in the medulla. And so as you can see, different things will trigger different zones. And this is how we slightly decide which agent to use if we have the choice. So in terms of managing nausea, it's really important to correct the underlying cause as best as you can. So for example, if there's an obstruction, if they have a virus or if they have a bacteria, treating the infection. Sometimes we need to adjust other medications. When someone's very nauseous, you're better to act proactively. So what I mean by that is don't prescribe anti-nausea medications as they're throwing up, because at that point it's a bit too late. If you know someone has persistent nausea and vomiting, I would schedule it so that we're ahead of it. Selecting the route is very important. If they can tolerate oral medications, then that's wonderful. But if not, then we need to either rely on IV and subcutaneous or rectally. Importantly, we sometimes forget about constipation. If you're constipated, there's nowhere for the food to go, and this can make nausea worse. And remember environmental controls. So control odors, cool damp to the forehead, neck and wrists, and remove smells in small frequent meals. Some ways that we can manage this without using medication is just diet modification. So very small, frequent meals throughout the day, liquid, soup, water. If there's a particular taste that bothers them, stopping any irritating agents such as like ibuprofen or other NSAIDs, and using our herbal and complementary alternative medicine. So things like ginger and peppermint have been shown to be quite helpful, things like lemon tea or cardamom. So again, when managing vomiting, treating should be mechanism-based and not generalized. I'm going to briefly talk about a few agents. So there's an anti-dopaminergic. One of my favorite ones is metoclopramide, and I understand this is sometimes available. This medication, you're going to start a dose at 10 milligrams. You can give it 4 times a day, so the maximum dose is 40 milligrams. This is a really great medication in someone whose gut isn't really working, or they tell you, I feel really nauseous after I eat. And the reason being is that it gets the gut moving. Okay, so it pushes food through. It's an excellent medication. And again, is wonderful for those cases where they say my nausea is associated with eating. If you're suspecting a bowel obstruction, so a complete bowel obstruction, this is not a medication I would recommend because there is some perforation risk. Another antidopaminergic is domperidone, again, 10 milligrams. This one is 3 times a day. This medication is also excellent. Haloperidol is a wonderful medication, and many of you might think of this actually more for anxiety and agitation, but it works very well for nausea. This is a great medication if you think that someone has a bowel obstruction because it doesn't have any prokinetic mechanism. Another agent, which is quite helpful, is a medication called ondansetron. And this dose you're going to give anywhere between 4 to 8 milligrams 4 times a day. And again, it can be given oral, subcutaneously IV. This is a great medication for someone who is either having side effects due to chemotherapy or has a viral gastroenteritis or some kind of electrolyte imbalance. The one thing I'll say about ondansetron is that if they're already constipated, this can make it worse. and just a few other broad spectrum agents that I find quite helpful. And so things like prochlormethazine, olanzapine, these target multiple receptors and so are good for just in a broad sense. Olanzapine is a wonderful medication if you think some of their nausea is related due to their anxiety, because olanzapine also manages anxiety. Let's catch up with Ahmed again. Unfortunately, Ahmed is starting to feel very anxious over his disease progression. His family is noticing that he's becoming quite agitated and confused. It's quite distressing to Ahmed and his family. So I'm going to very briefly talk about anxiety. With anxiety, most important thing is supportive counseling, just being present. You can use complementary therapies. There are options for pharmacotherapy, but sometimes if you can offer both pharmacotherapy as well as supportive counseling, the combination is the best. Various complementary therapies such as muscle relaxation, such as massage, guided imagery, meditation, aromatherapy can all be very helpful. If you have access to medications, some of the most common medications are known as SSRIs. The one thing I will say is this will take 2 to 4 weeks to see any benefit. They're generally well tolerated, and some various medications are available. So things like paroxetine, citalopram, escitalopram, and sertraline. Here in Canada, sertraline is one of the primary medications that we use and is widely available. But again, keep in mind that this can take quite some time to work, such as 2 to 4 weeks. Delirium and acute confusion is very common in the palliative care population, especially when they start to near the end of life. Delirium is considered an altered state of mind, so they're quite confused. But what's interesting is that sometimes they seem very much alert and oriented, but then sometimes at night they seem to be more confused. This is almost the definition of delirium, so it's known as waxing and waning. Acute confusion can be because of any kind of brain dysfunction, whether it be a stroke or cancer or just a change in environment. And so both delirium and acute confusion, these aren't really a specific diagnosis, it's just a collective term. So how do we manage this? Again, finding a quiet space where they can be reassured and having familiar faces, so family nearby, discussing and telling them what time of day it is and what day it is. One of the most actually common causes of delirium and acute confusion is urinary retention. So seeing if they're retaining urine. In terms of management, 2 agents that we like to use are things like haloperidol, which will start at 0.5 milligrams, which can be oral or subcutaneous, and you can use it every 4 hours, or olanzapine, 2.5 to 5 milligrams every 12 hours. If you have access to benzodiazepines, you can use things like lorazepam or diazepam. I will say, however, lorazepam and diazepam will help with the anxiety. If someone is very confused and they're elderly, benzodiazepines can make their confusion and delirium worse. So just be cautious. So in summary, the symptoms in a palliative care patient do significantly influence the quality of life. Whenever we're treating any of these symptoms, it's really important to understand and treat the underlying cause. I empower you to try non-pharmacologic measures first, as these are more accessible, and then escalate pharmacological therapy as required. And when you're thinking about it, consider whether oral or IV route is the most appropriate. Thank you so much. It was an honor to speak with you here today.